Medications, drugs. These words have a negative connotation in cycling, running, and triathlon, and for good reason. For too many years, athletes have abused pills, capsules, and injections to get an advantage over their competitors. However, the fact of the matter is that everyday athletes are using medication to treat infections, prevent heart disease, or manage their blood pressure. Even though these medications may not be performance enhancing, there are still important considerations that athletes need to be aware of. How do they affect your zones? Or are they legal, or do they need a therapeutic use exemption? Joining me today is Jeff Sankoff. He's an emergency room physician, athlete, and coach known as the TriDoc. We tap his incredible knowledge of not just medicine, but also physiology, athletes, and competition. So, let's hear a little more about the ins and outs of medicine before you pop that pill, and let's make you fast. Hey listeners, welcome to another episode of Fast Talk. This one's a little bit different. I don't necessarily have Trevor Connor sitting across from me, but I do have Jeff Sankoff, who is the TriDoc.
That is right.
Awesome. And the reason for that is Jeff is an emergency room physician. He's an athlete. He's a triathlon coach. He's on his way to being a cycling coach.
That's right.
And so he's a pretty good guy for our episode today. We're going to be talking about medication, things that you have to take. Your doctor prescribed it to you, maybe some over-the-counter stuff. And ultimately, what I want to talk about, though, is a little bit different. Just some considerations that you ought to have with the medication that you're taking. This is not to say you should or shouldn't take it. If your doctor has you on a medication, it's probably for a good reason. And any changes you should probably definitely discuss with your doctor. But as sports scientists, as athletes, we want people to be aware of maybe just, some considerations, how your heart rate might change, how your recovery might change, things of that nature, so that you can ultimately be the best endurance athlete that you can. Jeff, you want to start out real quick? Just let's hear about your background. Tell us about being a doctor. Tell us about being a coach and an athlete.
Yeah, absolutely. I came from Montreal, Canada. That's where I was born and raised. I went to medical school there. And when I finished my critical care training after doing a 5-year residency in emergency medicine and then a 2-year fellowship in critical care, I found myself at a little bit of a crossroads. I call it my Andy Dufresne moment, which was get busy living or get busy dying, because I was very much out of shape, very much overweight, and with a family history of a lot of heart disease, and didn't want to go down that road, and made a decision that I had to get in shape. And so started eating better, doing some exercise, and over the period of 4 or 5 months, started to lose some weight, and one of my colleagues noticed, and she said to me, what have you been doing? And
I told her, this revolutionary change in your life?
I told her I'd been doing some running and some cycling, and she said, well, you really should do a triathlon. And I laughed because I was like, yeah, no. The only triathlon I knew was Hawaii, and that was not something that interested me. And also, I didn't really know how to swim. Well, over the course of dinner, she kind of convinced me that that was something that I should think about. And over the next year, I learned how to swim and bought a bike and got a coach and did all the things that you needed to do and did my first triathlon. And after that, I was hooked. And so for the next 20 years, I'd just been doing triathlons and getting better at them slowly but surely until finally I had kids that were old enough to let me train in earnest.
There you go, yeah.
Over that time, I had the good fortune to meet some people who were writing or in the world of triathlon magazines and other publications, and started writing medical articles for different triathlon publications. And I don't know, just over time, just always loved the sport, always loved how it changed my life. And in 2018, decided I wanted to take the next step. And so I started a podcast, a TriDoc podcast, and then started coaching, got myself certified by USA Triathlon and Ironman University. And I've been coaching as TriDoc coaching ever since then. And actually got myself to that race in Hawaii a couple of times.
Did you?
Yes, I did.
Wow,
and the first person I called to tell that news was that woman who had first convinced me to do a triathlon, and who I said, no, never going to go to that race.
That's awesome. So you did figure out that swim side of it, sounds like.
Eventually.
For me, I will say I'm proof that you don't need to know how to swim to do a triathlon. You just need a wetsuit.
Yeah, it definitely helps. No question.
Saved my bacon, that's for sure. Yeah. Well, Jeff, I think that, today we should start the conversation with something that's really common for people to take, right? And that's over-the-counter NSAIDs, anti-inflammatories, pain medication that you might take. And, for me, I was looking into research here, and I'm really interested to hear your take. I was always under the impression that take an NSAID, go for a long run. It's a common thing for people to do, but ultimately you're going to be leading to some deep damage within your body. And I don't know that I found strong evidence for that. So I think that I want to start this off with a question of, is it safe to be taking NSAIDs while people are out exercising, doing some grueling things, not just a 5K, but marathons, ultra marathons, dehydration, all of that working in?
Yeah, it's a great question. NSAIDs account for billions of dollars of sales every year, and they're a huge boon to the pharmaceutical industry. The acronym stands for non-steroidal anti-inflammatory drugs, and they comprise a wide variety of different types of medications. They include the first one that was ever found, which was aspirin or acetylsalicylic acid, but have gone on to include much more commonly used ones today like ibuprofen, naproxen, which is naproxen, as well as several others. And with any medication that we take, every single drug that you will ever encounter, we have to always remember that for any positive beneficial effect that a medication gives us, there's always the potential for a risk. And those risks can be adverse effects that are very minimal. They could be minimal side effects, or sometimes they can be very, very dramatic. With non-steroidal anti-inflammatories, there's a second thing that we have to think about, and that is the effect that they have on exercise adaptation.
I'm glad you brought that up.
So, and that's an important one, of course, all of us as cyclists, we want to always consider as a medication that we're taking actually having an impact on our training.
Yep.
So let's start first with the risks.
Yep.
The most commonly known risks associated with every nonsteroidal anti-inflammatory is gastrointestinal bleeding. So what that means is bleeding from the stomach. We have a large amount of acid that's formed in our stomach as part of the defense to keep bad things out, but also to help our digestion. And we normally have a defense mechanism that is there that requires prostaglandins. And those prostaglandins help defend our stomach lining against that acid. When we take non-steroidal anti-inflammatories, we actually inhibit an important enzymatic pathway in the formation of prostaglandins. And that actually is why inflammation is decreased with nonsteroidal anti-inflammatories, because prostaglandins are so important for inflammation. Well, it also turns out prostaglandins are important for protecting our stomach lining. So, yeah.
Interesting. For me, I always assumed that it was the acidic nature of that ibuprofen or whatever it is, and not this prostaglandin inhibition. And I'm going to share a really silly story. I made a mistake one time. I was taking a red eye on a plane, and I had a splitting headache, so I wanted to take some Advil. But I didn't have any water, and I didn't want to bother the flight attendant or anyone else around me because it's like 1 o'clock in the morning. So I just put the Advil in my mouth, and I was like, I'm just going to let this thing dissolve. Well, that enteric coating is on there for a reason, and all was well and good until that coating wore off. And I ended up getting like an ulcer on the side of my mouth. I'm assuming from the acidity of this medication. And I quickly spit it out because there was no way I was swallowing it at that point. Anyway, I say all of this because I had assumed that that was the mechanism that ultimately led to an ulcer in your stomach, was the acidity. And so this prostaglandin side of things is really interesting to me.
Yeah, no, it's the medications that we take are not, even aspirin, which is acetylsalicylic acid, is a very, very weak acid. Its pH is only 6.4. It's very, very weak. When you consider this, the acid in the stomach is actually hydrochloric acid.
Sure.
And that pH is like 2.
Yep.
So when we talk about pH, the lower the number, the more acidic something is. And 6.4 is really not very acidic at all. Most drugs are weak acids, and I think ibuprofen is one of them.
Sure.
But it's really, really not a very strong acid at all, and it has no major effects on the stomach. As if you just put that drug on the lining of the stomach, it's not going to do anything.
Yeah.
The fact that it did something to your tongue is probably just irritation, as opposed to any acidity.
Yep.
That being said, you never want to leave something exposed.
Very
like that.
true. Yeah.
Now, the prostaglandin issue is the issue.
Yeah.
So again, nonsteroidal anti-inflammatories all work the same way. They inhibit an enzyme called COX-1 or COX-2. Most of them inhibit both. And that enzyme is important for forming prostaglandins. Prostaglandins work to cause inflammation. If you inhibit that enzyme, you don't have prostaglandins, you decrease inflammation. You also need prostaglandins to protect the stomach. So good by prostaglandins, good by defense mechanisms in the stomach. The acid can then cause ulceration. And if that ulceration goes deep enough, it can erode into a blood vessel and you get bleeding. So that's one of the major side effects of nonsteroidal anti-inflammatories. It doesn't happen to everybody. You have to take a lot of nonsteroidals. You have to take them pretty chronically.
For a duration of time.
Yeah. But a lot of people do. A lot of people take ibuprofen on a regular basis without recognizing that it has that effect.
Now, if I'm taking ibuprofen for a couple days in a row, I have a little SI joint issue that bothers me. Advil seems like it clears it up pretty well. I can end up with some stomach discomfort where I'll eat something, it doesn't quite sit right. Is that associated with what you're talking about?
It is. Yeah. It is. That's gastritis.
Okay.
And gastritis is just inflammation of the stomach lining, and it's the first step in that process towards ulceration.
There you go.
Now, you recover from that. If you stop taking the anti-inflammatory, then you'll be fine.
Yep.
But if you continually take anti-inflammatories and get that irritation of your stomach, it suggests that you have to be careful.
Right. And this is something endurance athletes, right? They'll feel a little sign, they'll feel a little something is off, and they'll just keep charging forward as if nothing was wrong until the situation blows up.
Unfortunately, we are notorious for that. Yeah.
I will say, it was hard for me to find Jeff. Actually, it wasn't hard for me to find Jeff. Jeff was recommended as a guest on the show from the Slow Twitch forums. But what was important to me was that I had somebody to talk to today who was an endurance athlete, who got it from that side, not necessarily just a doctor or pharmacist really knowledgeable. And so I'm glad that you're bringing this insight to the conversation.
Well, the second potentially bad side effect with nonsteroidals is one that doesn't cause so many symptoms. And that has to do with renal impairment or impairment of kidney function.
Okay.
So that prostaglandin issue, well, prostaglandins are also important for how the blood vessels within the kidneys react. It would be getting into the weeds for me to really get into this in great detail.
Yep.
Suffice it to say that our kidneys are exquisitely sensitive to blood flow. That is because they are very, very metabolically active. And the second you deprive the cells within the kidney of oxygen to a certain degree, they start to die. You need prostaglandins to regulate blood flow in the kidneys. And when you decrease the amount of prostaglandins around because you're taking nonsteroidal anti-inflammatories, you can jeopardize blood flow to those cells in the kidneys and result in something called acute tubular necrosis and eventually renal failure. In a state of dehydration, particularly, taking nonsteroidal anti-inflammatories increases the risk of renal failure. And as we all know, when we're exercising, especially in the heat, we are almost always, invariably, no matter how well we try to rehydrate, we end up in a dehydrated state. And as a consequence of that, the potential for getting renal impairment when taking nonsteroidal anti-inflammatories when exercising is significant and has to be considered. Even if you take nonsteroidals after exercising, if you haven't rehydrated adequately, there is that risk.
Interesting.
We don't know how common it is. It's not like I see patients coming into the emergency department because they went running that day, they took ibuprofen and they ended up in renal failure. It doesn't happen to that degree. But we know it's a risk. We know it's a possibility. And therefore, I always counsel my athletes who I coach, because I have several who come to me and they say, listen, I like to take an ibuprofen after the first half of the marathon because it helps me get through the second half with less pain. And I tell them, do not do that because the risk is simply too high and it's not worth the risk.
And that's what I was going to ask. Is there a safe amount to take? You know, let's say somebody goes based on the package recommendations. I know myself, the listeners of the show know that I have some long-term kidney issues that are autoimmune related. So I stay away 100% because of this. But it is really common for people to be taking these NSAIDs while doing, especially marathons or ultras even more so. Is there a safe amount, or is this like you're playing with fire as soon as you take a minimal amount?
I can't, in good conscience, provide a safe amount because what might be a safe amount for one person is not going to be safe for somebody else. So there's no way for me to say that there is truly a safe amount. The safe amount is zero when exercising. And using ibuprofen after exercise for aches and pains is generally considered safe as long as you stay within the recommended dose. And a lot of people go way over the dose because, let's face it, ibuprofen does have a pretty well-established safety profile, and we know that you can take large doses, but the higher the dose, the more likely the side effects of stomach and kidney problems. So you really should stay within the recommended doses, and you want to make sure you're well hydrated.
Can I ask, is there like a washout period? You got a big trail race coming up on Saturday, but your knee's bothering you, so you've been taking some ibuprofen. Is there a general recommendation like, hey, you should be off of it by Thursday, give it a day washout, or is there nothing like that?
The drugs are pretty well metabolized in a pretty predictable manner. Yep. When we talk about, these drugs are dosed every 4 hours. Mm-hmm. So when we talk about a 4-hour dosing, that usually means by 8 hours, they're completely out of your system.
Okay. So even stopping the day before, it's probably out of your system on race day, which means you're likely at no increased risk for an acute kidney injury.
Yes, that's correct.
Okay, awesome.
I do want to return to the other thing about NSAIDs, and that is their effect on adaptation to training.
Let's do it.
When you go out and train hard, you finish your training session, you often feel sore. You know you've worked out because you can feel the effects on your muscles. Those effects are inflammation. They're inflammatory effects. We want that inflammation because what's happening is you're causing almost micro damage within the muscle. And the repair mechanism is basically the process of inflammation. It involves the inflammatory cells rushing to the damaged muscle areas. It involves the removal of the different damaged fibers and the rebuilding of those fibers in a stronger, more effective muscle cell that will be able to handle the stress load that you just gave them more effectively. Mm-hmm. If you interfere with that process by giving an anti-inflammatory medication, you decrease the adaptation in those cells.
Right.
And it has now been shown in several studies that taking anti-inflammatory medications during the adaptive phase of training, specifically that phase of training where you're really trying to build, you can actually decrease performance.
Right.
Now, this is true for younger athletes in their basically teens, 20s, 30s, 40s. Once you get into my age group, 50s, 60s, we tend to live in a heightened stage of inflammation.
Okay.
And that is to say that as you get older, your inflammatory processes aren't as well checked, and you tend to always be in a more inflammatory
state. So you're always adapting.
Well, the problem is that that inflammatory process tends to do more harm than good.
Sure. Yep.
And in that case, taking anti-inflammatories may actually be a little more helpful.
Interesting.
And there's a lot of evidence now coming out that says, actually, if you have some delayed onset muscle soreness after doing exercise, taking anti-inflammatories in your 50s and 60s, again, with the caveat that that's also a higher risk for renal and stomach stuff, that actually is probably not so bad. It may help.
Yeah, it's interesting. I think that oftentimes we see athletes undergo strategies that help them train more. If I take this NSAID, this ibuprofen, is Tylenol an NSAID?
So Tylenol is not an NSAID. Tylenol works completely differently. It has no effect whatsoever on the COX enzymes. It does not affect the stomach or the kidneys.
People will take medications like this to decrease soreness so that they can train more, so that they can get better adaptation. And it often is important that we're recommending or reminding, maybe is the better word, hey, it's not necessarily about training more. It's about improving your adaptation to that work that you're doing. That's efficient training, whether that's the supplements you're taking or the intervals that you're doing or the amount of base volume you're doing. And we have had this conversation before in regard to antioxidants, right? Taking very large amounts of vitamin C or NAC, N-acetylcysteine, can also decrease it through similar mechanisms, the adaptation that you have to that bout of exercise.
Right. It comes back to what I said at the beginning. Everything we take has a risk-benefit profile.
Yep.
And we always have to think, we want to stay on the benefit side without getting into the risk side as much as we can. And I just want to mention about Tylenol. Tylenol, pretty safe drug, but very dangerous the second you step out of the recommended dosing. So please be careful with Tylenol.
Right. And that's a high incidence of very significant liver injury when you take too much Tylenol.
Yeah, it's the number one cause of liver transplant and acute liver failure. Tylenol remains number one.
Yeah. So real quick, kind of while we're talking about Tylenol, do we have any of these other let's say an endurance athlete is taking Tylenol within the recommended dosage. Are there any really considerations with that as a particular medication, like we talked about with the NSAIDs?
Yeah, Tylenol doesn't seem to impair the adaptation phase of training, so it can be used for pain control. There were some people who used to think that taking Tylenol during an activity like a race, that it might help because Tylenol has pretty good effects on controlling temperature. We take Tylenol to decrease a fever, for example, and people used to think, well, maybe if I take Tylenol during a race, it'll help me keep my core temperature down. And studies have shown that it does not do that, and it doesn't seem to impair performance, but it doesn't help performance either.
Yeah, sure. And so if anybody is out there doing some research on their own, like I encourage everybody to do, you might also see the term parsimetol, which is Tylenol as well, but by another name.
Yeah, it's just how it's called in the UK.
The UK.
Yes.
Before we take our first break, let's hear from Brady Holmer, who has another drug that can blunt adaptation to exercise.
Metformin seems to blunt adaptations to exercise training. And this has kind of become popular because metformin is kind of quoted as being this maybe longevity drug because it's going to promote, healthy metabolic health and promote maybe a healthier lifespan. But there have been studies showing that exercising while on metformin can blunt some of those beneficial adaptations to exercise. So I think people should be wary of if they're using metformin, whether they've been prescribed it for diabetes or maybe they're experimenting with it as this whatever longevity drug or however you want to phrase it. They should be aware that it can interact with exercise and may limit some of the adaptations you're getting from that.
'Tis the season for spring knee. As sunshine and spring weather inspires us to ramp up our riding mileage, our knees don't always keep up. If you got knee pain, we have the solution for you. Fast Talk Lab members can follow our knee health pathway, featuring Dr. Andy Pruitt. See the introduction in the knee health pathway at fasttalklabs.com.
Jeff, that was an incredible opening segment. We started out with NSAIDs, which is probably the most common thing that people take. I'd love to jump over to some heart-based medication that are some of the most commonly prescribed medications, and that is antihypertensives, blood pressure medications, and also statins. Is there one that we want to start with first?
Why don't we start with blood pressure just because that's more common than statins?
Yeah, certainly. I think that there's a lot of athletes who are out there. I'm one of them. I'm 42 now, but I've been hypertensive for a few years. Seems like it runs in my family. My mom was always hypertensive. And so I've been on blood pressure medication. And it's just interesting to me. A lot of people are surprised by that. 42-year-old on blood pressure medication, does a lot of endurance work. That's supposed to be great for your blood pressure. And so it was important to me that we talk about this because so many people out there are so many athletes who are on blood pressure medication. And I love to peruse things like the Trainer Road Forum, the Fast Talk Forum, got to plug our own, Slow Twitch. People are always asking questions about these blood pressure medications. And I'm not sure if there were some that you wanted to talk about, but there are two classes that I really wanted to talk about, and that's diuretics and beta blockers.
Yeah, those are definitely among the more common ones. Blood pressure medications come in various classes. There are the two you mentioned. There's also calcium channel blockers, ACE inhibitors. ACE stands for angiotensin converting enzyme inhibitors. There are the ARBs, that's the angiotensin receptor blockers. So there are various classes, but I think you're right. Beta blockers and diuretics are going to be the ones that will probably have the most impact on endurance athletes, and they're very common.
Definitely.
Just to go back to your comment about how you're younger and you're on antihypertensives, there's a reason more and more people are on these medications now. One of those reasons are that the guidelines for starting antihypertensives have changed in the last 5 to 10 years. And so the upper limit of what we consider normal has changed. It used to be 140 over 90, and that changed recently to 130 over 90. So that gives a kind of a different threshold for when people are going to be started on medications.
I laugh at 130 over 90.
And you also have to put this into context with family history and all kinds of things. But we know that blood pressure is a silent killer. It is a major determinant of heart attack and stroke. And getting blood pressure under control can have really, really important long-term benefits. So we definitely want to take care of that. Diuretics are generally considered a first-line medication for many people. It depends a little bit on different characteristics of the patient, things like that. But the reason is because they tend to have less potent effects and less side effects. And the most common one that's used for blood pressure control is a medication called hydrochlorothiazide. It basically causes salt wasting in the kidneys and lowers blood pressure simply by just decreasing overall blood volume. But it also seems to have some effects that we don't really understand, kind of a little hand waving and magic.
Like a lot of medication, it seems like. It's like, we think this is how it works, but I don't know. It does what it does.
Yeah, because there are other medications that, like, for example, there's a medication called Lasix, which is a much more potent salt wasting medication, and it doesn't really have any effects on blood pressure. So we're not totally sure how thiazide diuretics work to decrease blood pressure, but it does.
When you say salt wasting, can you explain that a little bit more?
Yeah, so thiazide diuretics work on an area in the kidney that prevents the reuptake of sodium. So our kidneys do a variety of things, but one of the most important things they do is manage our total body water. But our kidneys don't do a great job of actually handling water. Instead, they do a great job of handling salt. And water follows salt. So when we need to hold on to water, we just suck up all the salt that we've filtered out, and water will follow it. And so the kidneys do a great job of just handling salt. But different thiazide diuretics, they block one of the channels that is involved in the reuptake of salt. And by doing that, we lose more salt and we also lose more water.
So when we're losing salt, I think that begs an obvious question from me. Athletes that are taking this, are they at increased risk for something like a hyponatremia or increased rates of dehydration?
It's more dehydration because thiazide diuretics are not potent diuretics. As I mentioned, furosemide, which is called a loop diuretic, works much more profoundly.
And that's the Lasix.
That's Lasix, yeah. And that is, the loop diuretics are profound diuretics, and you'll lose huge, copious amounts of salt and water. Thiazide diuretics will increase urination. They will increase salt and water loss, but it tends to be matched. So you're not losing water in excess of salt, which would lead to things like hypernatremia, and you're not losing salt in excess of water, which would lead to hyponatremia. So you tend to lose them in a balanced manner, but you are losing more than you would normally. And so, yes, if you are on a thiazide diuretic, you need to be cognizant of that. And most people who are on it, usually they notice some increased urination for the first couple of weeks, and then things kind of get into a balance, and they tend to not have as much of a problem. But everybody's different, and it's impossible to predict.
Now, as somebody is settling into this lower total body water, right, they're going to have less circulating blood volume, I assume, right? And so that's probably going to increase? Do we see an increase in submax heart rate? Are people's exercise zones going to be changing at all?
Generally not, because again, our bodies will always fight for what's called normostasis. So if we take a medication that kind of sets off a process where we start losing water, we have other processes that are going to fight to restore that. Our bodies are always looking for this balance. And even though the medication is going to tip us over a little bit, we have other processes that are going to make us thirsty, that are going to make us crave salt, and we're going to try and get back into some kind of state of balance. And like I said, thiazide diuretics are not that potent, and so our bodies will win that battle. So most of these athletes will get to a point where they're actually euvolemic, meaning they're at a normal body volume. However, they're going to be more prone to getting a little bit more dehydrated faster because of the diuretic effect. Because while they're exercising, the diuretic is still working. Whereas yours and my kidney would, as we start to get dehydrated, yours and my kidney are going to act in a way to hold on to salt more efficiently. A person who's on a diuretic is not going to do that. And therefore, they're going to be a little more prone to getting dehydrated quicker. So that's where they have to be careful. When they're exercising, they just have to get on their fluids and their electrolytes quicker.
Certainly. Now, what's really interesting, in my opinion, about this diuretic conversation is there's a relative lack of negativity associated with taking with this, right? Your cardiac output isn't necessarily changing in a meaningful way. There aren't necessarily other systemic effects that you have to be worried about. But as far as I know, and I'm going to encourage everybody to check this, especially if you're on these medications, all thiazide diuretics are banned by WADA because of their masking ability, right?
Correct.
If somebody is taking a banned substance and you take a medication that increases your urine output, then you may be able to mask that banned substance that you were taking. And a great resource for people to be looking into is called the Global DRO. It's a website that you can put your sport, how you engage with the sport, whether you're an athlete, a coach, an official, your nation of purchase, and then the medication that you're taking. And it will tell you, is this banned in competition, out of competition? And so anybody, even if you're taking medications that have nothing to do with what we're talking about today, I recommend that you look into, for all competition, but especially people where you might fall under a USADA or a WADA situation, you really need to know and be aware of this resource.
Yeah, and the TUE process is not complicated and not that difficult, and you can get a therapeutic use exemption for blood pressure medications quite easily.
Very nice. Hey, can we jump over to the other blood pressure medication, the beta blocker?
Yeah, of course. And just to give a brief rundown, beta blocker refers to a specific receptor in our body called the beta receptor. There are two of them, beta 1, beta 2. The beta 1 receptor is found principally in our heart. The beta 2 receptor is found in our blood vessels and also in our lungs. Mm-hmm. So asthmatics take a medication that is a beta 2 agonist. So it is the opposite of a beta blocker. It is actually, an agonist is the opposite of a blocker. It's something that acts on the receptor. And beta 2 agonists like albuterol work on that beta receptor to cause bronchodilation or the opening of the airways. So works very well for asthma.
Yep.
A beta blocker, conversely, works to block those receptors. So asthmatics can't take beta blockers. It causes problems for them. But non-asthmatics can take them because what it does is it blocks the beta receptors in the heart. So it slows down the heart. But it also blocks the beta receptors in the smooth muscle of the peripheral arteries. And that's how it works on blood pressure. So it's doing two things. Number one, it's decreasing the force of contraction of the heart. And number two, it's opening up the blood vessels in the periphery, allowing for a decrease in blood pressure on both ends. Because blood pressure is determined by the force of cardiac contraction, but it's also determined by how much squeeze there is on the blood vessels in the periphery. And beta blockers work much more effectively than thiazide diuretics to decrease blood pressure.
Yeah, certainly. As far as I know, beta blockers are one of the earlier antihypertensives, right? And so I think that they're still pretty commonly prescribed for individuals, regardless of whether or not they're athletes, as opposed to maybe some of the newer, more selective things like you had mentioned before, the calcium channel blockers, the ARBs, the ACE inhibitors. But the beta blocker, I think, is something that we certainly have to talk about because it is decreasing this activity. We can see some profound changes on blood pressure, but also profound changes on things like heart rate.
Yeah. And the reason beta blockers are still widely prescribed is because they're incredibly effective at decreasing morbidity and mortality, especially in people who've had any kind of primary heart event. So if you've had a heart attack before, if you've had any kind of dysrhythmia, meaning your heart beating in a chaotic pattern, atrial fibrillation, or even any kind of ventricular issues, beta blockers will regulate that and prevent those things from happening again. So beta blockers, really, really effective, really, really positive types of drugs. But as you mentioned, they decrease heart rate and they decrease the ability of the heart rate to increase as needed during exercise. And one of their major side effects is to limit exercise capacity. And it's a reason why a lot of people can't be on them, because anybody who's active may find that beta blockers don't work for them because they want to continue being active and they just can't because the beta blocker restricts their heart rate.
Yeah, I think I've seen numbers of decrease in heart rate up to about 30%, right? And so if you're normally used to exercising at 150 beats per minute, then you might have a hard time getting close to 110 at that point in time. And, that decrease in cardiac output and likely VO2 max associated with that is probably going to severely limit exercise performance. But, as you mentioned, there are people who have gone through events, especially cardiac events, where this is an amazing medication for what you have. And unfortunately, you might have to live with this limitation. But Jeff, can I ask, what should people be looking for if they are taking a beta blocker? And what should the conversation be with their doctor to maybe end up on a drug that's a better fit for them in their lifestyle?
Yeah, it's risk benefit, right? Just like I said with the NSAIDs, you have to consider what your profile is and what you want. I had a hip surgery. I had a reconstruction of basically a shredded labrum. And I went back to my orthopedic surgeon after everything was said and done. And I said, can I go back to training for an Ironman? And he said to me, I never see athletes who run 10Ks. And I said, okay, but can I go back and doing an Ironman? And, this went back and forth.
He was implying something.
I know what he was
here.
implying. And we went back and forth for a little while. And he said to me finally, he said, look, we didn't do this operation for you to not be able to do what you love. So you have to make the decision about whether or not you want to take the risks of doing what you love and potentially have to come back and see me again versus doing what I'm telling you can do, but potentially not enjoying what you enjoy.
Yep.
And it's the same thing with beta blockers.
Yep.
You may go to your doctor and say, listen, this beta blocker is restricting me from being able to climb Flagstaff in the time that I used to be able to do it. And, your doctor may say to you, I don't see patients who climb Flagstaff after, having had what you've had, if they are on a beta blocker. And so you have to have that conversation, and you are going to have a frank conversation with yourself about what it is that you want to accomplish and how long you want to be accomplishing it for.
Yeah.
Look at Leonard Zinn, right? Same issue.
Yep.
He had to give up cycling. I don't think most people have to give up cycling if they're on a beta blocker.
Yeah.
But it's an example of somebody who had to make a very, very difficult decision based on, did he want to continue doing what he loved and in doing so potentially end his life?
Yep.
I don't think that's what most people on beta blockers have to face.
Yep.
But it's a very extreme example of what we're talking about here. And I think if you're on a beta blocker and you're finding, look, you can't reach the maximum heart rate that you need to, or if you're getting lightheaded when you try to go hard, you need to have a frank conversation with your doctor and say, look, is there an alternative that will confer the same benefits and confer the same risk reduction? And if there isn't, then you need to think to yourself, have a conversation with your family. Okay, can I be happy doing things at a new level, or do I need to stop and find something else? Or am I just going to take a risk and switch to a different medication class and understand that I'm going to be at a higher risk?
Right. Yeah, I think that Leonard ended up at a pretty reasonable alternative in that I think that his dysrhythmia was associated with crossing a particular kind of heart rate where then he would have an increase in his dysrhythmia. He ended up riding an e-bike a lot.
Right.
And that made all the difference in the world. He's still able to get out and enjoy riding.
And it's a great example of how you can modify if you have to be on one of these medications. Listen, at some point, we're all going to have to make changes based on getting older. And we can't do everything that we did when we were young. I mean, listen, my 14-year-old is beating the pants off of me in almost everything right now. And it's great. It's wonderful. But at the same time, it makes me realize that, I'm going to have to adapt a little bit. And it's okay. It's okay. It's like adapting as you get older is just a fact of life. And you know what? As long as we can find the enjoyment in those adaptations, I think it's okay.
Yeah. Let's take a quick break from beta blockers to hear a funny story from Dr. Steven Seiler and also his views on balancing medication and the enjoyment of sports.
One burning memory that is kind of funny, but also a little bit strange, is that I had a cycling colleague back in the day in Arkansas, and he was bipolar, and he was using lithium, or a lithium-ish drug, and when he would sweat, his sweat ate up his bike. So that's the only example I have of the direct effect of a medicated athlete, that the medicine was destroying the bike. I don't think it was doing him any harm, but it was destroying his bike. So that's the humorous side of it. But as far as the realities of taking high blood pressure medicine, maybe antidepressants and so forth, the high blood pressure medicine obviously beta blockers and so forth will impact physical performance. And that's a tough reality for a lot of long-term athletes where they're used to having a certain capacity, but now they've developed arrhythmias or blood pressure and they're using these beta blockers. And your identity, as an athlete, I think is challenged because you have to decide between this evil, which is the disease or the disease state, and my self-image has just taken a huge hit. And so I think that's an interesting psychological reality. I faced it a bit with atrial fibrillation Trevor, you faced it with AFib. I never was medicated, but I was in that period when I was struggling a bit and having a lot of AFib episodes, I was really feeling like, wow, my quality of life has just gone down the toilet. I'm never going to be able to be an athlete again. I can't do these tough workouts, And fortunately, I was able to turn it around, and it was a lot of stress in my life. But that's what I see, is that just our understanding of our bodies changes when we have to use medicines or we are given a diagnosis.
Interestingly, with beta blockers and the research that I did, it doesn't seem like there's any deleterious effects on strength. So strength training seems like it's unaffected.
Correct.
Maximal power. If you're a track cyclist, maybe you're just fine, doing track sprints on a beta blocker. In WADA, it's not banned for any endurance
interestingly
sports.
enough, it is banned for certain things. So, for example, and this is obviously not going to be this audience, but biathlon.
I was going to say, because,
cross-country skiing. A lot of those events where your heart rate is super high, beta blockers are banned in those sports because they use them. So a great example is biathlon, where they're skiing in this incredible effort, and then they have to get their heart rate under control so they can level the gun and shoot at those tiny little targets. And beta blockers have been used by some athletes to be able to keep their heart rate under control.
The list is like biathlon, archery, bowling, darts, things of that nature, right? Because of that calming effect. And it's interesting. Recently, I've been seeing ads promoting beta blockers to people who don't have any hypertensive issues, but who have like a stage fright, and they have to be in front of large audiences.
Yes,
right?
It's because it keeps anxiety under control. It's actually another indication for using beta blockers.
Yeah.
And again, the drug companies, right?
They're going to find any way
ways
sell it
to pad their bottom line. But it is effective. But there are dangers. I mean, if we see patients who get syncope or fainting spells from being on beta blockers. So there are dangers.
Cool. What do you think? Should we jump away from the heart and jump over to statins?
Yeah, absolutely. Statins very much related to the heart. So yeah, I think so.
Right. Yeah. So, statins, at least according to GoodRx, are one of the number one prescribed medications in the world. And ultimately, it's because they're looking to reduce LDL cholesterol, low density lipoprotein, which is associated with things like heart disease and stroke. And there are people that we've had on the show before. Dr. Inigo San Milan is a huge proponent against statins. Just mention that word around him and just watch his ire fly. I love the passionate nature that he has. But, we commonly hear about things like myalgia, like muscle pain and muscle soreness associated with statins. So I'd love to start there.
Yeah. I didn't know that Dr. San Milan was so against statins. That's interesting.
Let's insert a clip here.
We don't know quite the mechanisms. We know the statins, and it depends if they're like a high dose of statins or like a lower potency of statins. They inhibit complex 1 in mitochondria. So you don't want to inhibit complex 1. We know that many statins down the road, they significantly increase the risks of diabetes because they're more diabetogenic, right? Especially what is called the high intensity statins. And it probably could be because they inhibit mitochondrial function down the road. So it's a little bit of a counterintuitive, or desiring to live longer when you might down the road inhibit your mitochondrial function, which is a key process of aging.
First, just to address that, listen, statins are widely prescribed for a good reason. I have nothing but the utmost respect for Dr. San Milan. I actually am trying to get him for my own podcast because I just reviewed his paper on the periodization of carbohydrates. I think he's fascinating, and I really would love to chat with him. But with all due respect to him, he's not a cardiologist, nor am I. I don't play one on TV either. But I do think that statins have a very, very important role for anybody who is at risk or has had a heart attack, because they dramatically decrease the recurrence of heart attacks and they dramatically decrease primary cardiac events in patients who are at risk. That being said, they do have important side effects. Like we talked about before, every medication has risk-benefit, and there is a pretty important risk profile for all statins. And it's important, especially for this listening audience, which is an active listening audience. And we know that myopathy, which is what we're talking about, the muscle complaints that have been associated with statin use, they can vary from mostly benign, but they can be life-threatening. And they happen in anywhere from 10 to 15% of patients. And they are important. And if you're on a statin and you get them, then yeah, it's going to be a big deal for you.
Right. And it seems like people are commonly reporting what this sort of muscle ache, this muscle soreness, oftentimes it's in their calves and their thighs is something that I came across.
Yeah, that's true. That it tends to be thigh, calf pain are the most common complaints.
Mm-hmm. Yeah, certainly. Now, something, and I don't know if you can fill in this blank for me, when I was researching this episode, I did not necessarily see a clear reason. We know that this is occurring in 10 to 15% of people. This is a real situation. I did not see an etiology to understand what is the actual mechanism that is causing these muscle pains.
It's interesting. It's happening at a very low, biochemical, it's really in the weeds. But basically what's going on is statins decrease coenzyme Q10. Mm-hmm. And that seems to have an effect on mitochondrial function in muscle cells.
Yeah.
And as a result of this, people who are on statins, not everybody, again, only 1 in 10, maybe 15%, will develop this kind of muscle pain. And in fact, there have been studies that have shown if you supplement with CoQ10, anywhere from 100 to 500 milligrams per day, that can actually help decrease the incidence of these symptoms.
Yeah. Now, can I ask, and maybe this is just an opinion, right? And we're on a podcast. This is not medical advice, I don't think. In people who are taking a statin, but not necessarily feeling any of these symptoms, feeling the myopathy or the myalgia, the muscle soreness, is there potentially an effect that's occurring that's affecting their performance? Or if you're taking the statin and life is grand, keep on keeping on. It's not doing anything negative to you.
Yeah, I haven't seen anything that suggests that taking a statin decreases performance. But I don't know that anybody's really looked at that.
Sure.
Statins have been looked at for a wide variety of things because the enzyme that statins inhibit, which is HMG-CoA, which is neither here nor there.
Very nice. I'm going to have that tattooed
it's
on
an
me.
HMG-CoA reductase inhibitor. That enzyme is found in a wide variety of different processes. And so statins have been looked at in all kinds of things, in treating sepsis, in treating inflammatory process, all kinds of things. And thus far, there's been kind of plus minus in terms of how well it works.
Yeah.
No question, big benefits for cardiac stuff. I haven't seen anything that suggests that it improves or decreases actual endurance performance. But again, there's not too many young people taking this, and that's generally where most endurance research is done.
Yeah, certainly. This is a decision that I'm going to have to be making pretty soon here because of my chronic kidney disease. My nephrologist is concerned that my cholesterol is probably quite elevated because of all the protein that I'm leaking, and has requested that I get some blood workup done, and we might have to make that decision of, is a statin right for me? And I know that as much as I have this little bit of a fear and anxiety around it, I think that the first step is, if it's indicated, then to give it a shot and see from there, and then make kind of an individual decision, because we do have to be putting our health first. And even though we're all athletes, sometimes we do need to consider sort of more of the long-term wellness and longevity side of things as opposed to the acute, what am I going to be able to do tomorrow?
Yeah, and again, I want to come back to those risk reductions. They're very impressive. We're talking a 25% decrease in the risk of myocardial infarction and death in people who have had a previous cardiac event, and a 10% decrease in the chance of developing cardiovascular disease within 10 years for people who are at risk. So that's pretty significant. Mm-hmm. And again, if you fall into one of those categories, then if you have a conversation with your physician and you go over all of this, then I think he or she should be in a good position to guide you, and together you should be able to come up with that. And those are real risks. I mean, we take a lot of medications for a lot less benefit than that.
Right. Yeah. Now, so we're talking about, the opposite, or I shouldn't say the opposite, but the risk is some muscle pain, some muscle soreness, 10 to 15% of people. There is, as far as I know, a significantly more damaging situation that occurs less frequently, and that is an increased incidence of rhabdomyolysis. Myeliosis?
No, it's rhabdomyolysis.
Okay, that's what I thought. Yeah. And that's 1 in 100,000 cases. And I didn't find any solid research that was really tying these together. But I did see a couple case studies, 50-year-old marathoner presents with, acute rhabdo and was taking a statin. Is this something that you've seen? Is this something that you can comment on?
The only thing I could say is that it seems to be associated with statin dose and less related to actual exercise.
There you go.
So again, those are case reports. And so you're more likely to get rhabdomyolysis if you're running an ultra or a marathon. And the fact that the person was on a statin, it's not clear if the statin caused it or if they're just, they're coincidence.
Yeah.
But we do know that there have been cases where people who were not doing exercise developed a case of rhabdomyolysis and they were on a high level of a statin. And if you looked at the cells, there was some biochemical issue that made it seem like the statin was involved and it was a culprit.
Yeah.
But they're so rare that it's really hard to tie the two together. But it seems at this point that there's been enough cases that the higher dosing of statins can be related with rhabdomyolysis.
There you go. I'd love to wrap this segment up with talking about maybe some alternatives that people can do if they're concerned or if they are having some negative effects associated with statins. I think that the common things that are talked about, right, to decrease your bad cholesterol, increase your exercise. Hopefully that's not an issue with people that are listening to this, but it could be increasing things like fiber intake, decreasing your alcohol consumption. Interestingly, I saw it increased in whey protein supplementation was correlated with a decrease in LDL cholesterol. And then a couple other things. You had mentioned supplementing with coenzyme Q10, CoQ10. That seems like it might help alleviate some symptoms. And I also came across supplementing with vitamin D and carnitine as well. May be beneficial. I think that it's hard to say at this point, right? Because we don't really understand that mechanism too well. Maybe that's a little bit of a shotgun method, just throwing some stuff, seeing what sticks. But maybe there's some more science behind the CoQ10.
The CoQ10 is, again, just related to the fact that when you take statins, you decrease the production of it. And so you're supplementing it exogenously. As for everything else, all the dietary stuff, usually most people have tried the dietary stuff before they're put on a statin, and there is nothing as good as a statin. Nothing will reduce your numbers as fast or as dramatically as a statin will. That being said, combining all of those things will do even better.
There you go. Pathways from FastDoc Laboratories are a new way to explore concepts, master skills, and solve training challenges. Our new cycling interval training pathway begins with the basics of interval workouts and progresses to more advanced details, how to flawlessly execute interval workouts, which intervals bring which adaptations, and how to analyze your interval workout performance. Over 21 articles, interviews, workshops, and workouts, our new cycling interval training pathway offers you the chance to master cycling's most critical and nuanced workout format. See this pathway at fasttalklabs.com. Well, Jeff, we just covered a couple medications that people are on probably long-term, multiple months to multiple years. Let's cover something that's maybe a bit more of a short term. There's some considerations when athletes are taking antibiotics.
Yeah, antibiotics are another one of the big boondoggles for drug companies, and they are a very widely prescribed medication that unfortunately probably doesn't need to be taken as often as it does. We take antibiotics for a wide variety of reasons, but the vast majority of them in adults tend to be for respiratory infections that don't require them.
Sure.
When we get a respiratory infection, 90% plus are viral, which don't respond to antibiotics. So infections, when we think about an infection is caused by a virus, it's caused by a bacteria, it's caused by a fungus, one of those three things. Viral infections comprise the vast majority of infections. Bacterial infections are the only things that respond to antibiotics. Fungal infections are exceedingly rare. If you do get a fungal infection, it's usually because you have a depressed immune system or some other special circumstance. Fungal infections are generally more chronic and indolent, but need special antifungal medications.
Sure.
What's the issue with taking antibiotics if you don't need them? First, let's just talk about our sort of societal kind of pressures that lead to antibiotics being taken as much as they are. None of us want to be sick.
Nope.
And we kind of all grow up in an environment where when we're sick, we go to the doctor and we have this expectation that we're going to leave with a piece of paper that, at least if you're my age, you left with a prescription that you went to the pharmacy and you got a pill bottle and you took something cherry or banana flavored and you got better in a few days. We've learned over time that taking antibiotics when you don't need to take antibiotics leads to, again, this whole risk-benefit balancing act. There are risks associated with antibiotics. Number one, we predispose ourselves to infection by bacteria that are resistant to those antibiotics. Number two, we teach bacteria to be resistant to antibiotics. And number three, we cause problems within our own bodies because we are administering antibiotics to our organism that is populated by a wide variety of bacteria on a normal basis. That little ecology within ourselves called the microbiome, which we wipe out when we give them antibiotics, and we then leave ourselves prone to all kinds of problems.
And I will say, this is one of the most mind-blowing concepts about the human body to me, is the variety of the microbiome, but also the importance of the microbiome to functions throughout our entire body, right? Okay, I can understand that we have some bacteria in our gut and that they help us digest and absorb food. It's a pretty direct link. I get that. It's amazing to me, though, that there is a link between our brain, our mood, and our gut microbiome and the interconnectedness of all of that. We really are talking about a holistic, systemic conversation here.
Yeah, and what's been really, really interesting to me has been recent studies that have shown how the microbiome impacts performance. That when you wipe out the microbiome, endurance performance is dramatically affected. Like, just mind-blowing stuff. And that's why I have always been on a bent where don't take antibiotics if you don't need them. It's bad for us societally. It's bad for us just in general. And now I'm realizing it's bad for us individually as athletes. You don't want to take antibiotics unless you really need them. Now, there is no question. If you have a bacterial infection, then yes, you should be on them.
Yes.
And I am not the one to tell you not to take them.
Yes.
But
your doctor is the one to tell you not to take them.
The vast majority of people who get prescribed antibiotics almost never need them. I constantly hear people telling me they have sinusitis. Sinusitis is viral 99% of the time. I constantly hear people telling me they have bronchitis. Bronchitis is viral 100% of the time. And yet, a lot of doctors will prescribe antibiotics because the patients will demand it or because the patients believe they need it. And sometimes the doctors just don't want to be bothered with spending the time to explain or listen, we work in an environment where healthcare is a business and the patients are the customers and the customer's always right. And so it's an unfortunate setup.
Yeah.
I am pleading with you, the listeners. Please, if you think you need antibiotics, go in with an open mind and don't demand them. And instead tell your doctor, look, if I don't need antibiotics, I don't want them. Because you as a patient will be better off not getting antibiotics if you don't need them.
Right.
Because of these impacts on the microbiome.
The advice isn't, if you're sick, just suffer through it, you're going to get better. That's not the advice given. The advice is still, hey, if things are wrong, go talk to your doctor, but don't think that this is a magic bullet.
Exactly. Exactly. Now, the impact on the microbiome. When you take antibiotics are indiscriminate. If you have a bacterial infection, the antibiotics will take care of those bacteria, but the antibiotics don't really care which bacteria are causing your infection. They're going to take out everything. Yeah. And our gut is populated with bacteria that help us, like you said, with digestion. And it turns out a lot of that digestion is, so when we exercise and we're taking all these long chain polymeric carbohydrate, a lot of that is just basically, another word for that is fiber. Yeah. Well, we don't digest fiber, but those bacteria do. And those bacteria chop up those little fiber into little, much more manageable short chain carbohydrates that we then digest and then absorb and then use for energy. Well, when we wipe out our microbiome, turns out we don't do that so well and we don't perform very well. But there's more to it than that, because it also turns out that those microbiota appear to have an impact on how our muscles work. It's not clear exactly how, but they're tied together somehow. Yeah. Just like you said before, the brain and the mood and everything else. I mean, there's all these ties. And they have done experiments where they fed groups of mice. I love this experiment because they had these 3 groups of mice and they had them running, like doing these training sessions on these little mouse-sized treadmills. And they would feed them the same diets, and then one group would get antibiotics and the other group wouldn't. And it turned out that in a test to exhaustion, the ones who got antibiotics performed terribly, and the ones who didn't did great. And then if you took gut bacteria from the healthy mice and transplanted them into the mice who had received antibiotics and did nothing else, they performed the same as the other ones. So it was not that the antibiotics made them worse. It was just the loss of their microbiota. And transplanting microbiota, not doing any extra training, made them perform the same.
That's incredible.
So it just, to me, highlights not only the importance of our microbiota and how much we have to protect it, but it also tells me how careful we have to be about taking antibiotics only when we absolutely need them as athletes.
There you go.
And if we do need them, if we do have to take them, there are some things that we can do to try and replenish our microbiome as fast as possible. There are various probiotic foods that are fermented, like pickles, kombucha, kimchi. All those foods do a good job. Foods that have active culture, like yogurt, cottage cheese, those are really good at helping to replenish. And you can actually buy these little capsules of lactobacillus, which is a big part of our microbiome. So if you have to take antibiotics, after you finish the antibiotics, you can eat those foods, take those capsules, and you can help to speed up the pace at which your microbiome gets replenished.
Is the after you finished, is that kind of an operative in this situation? Are you undoing, like if you're eating the yogurt while taking the antibiotic, is the yogurt not necessarily beneficial until after you finished your course of antibiotics?
There's actually, so one of the side effects with antibiotics is very commonly diarrhea. And it turns out that eating yogurt while taking antibiotics can actually prevent diarrhea in a lot of patients. So there's no harm in taking these things at the same time, but the longer term benefits will be after you finish the antibiotics, because anything you take while on antibiotics is going to get wiped out.
Perfect. Before we learn more about fluoroquinolones, let's hear from athlete Jack Burke about his experience with antibiotics and Achilles tendon injury.
I don't take anything for medication at all because I've just always found it just tends to set me back more than it is. But like one of the nice assets that I have going for me is I've only been sick once in the last 12 years. Like I never get sick ever. When guys would talk about like, you're going to get sick if you overtrain and stuff like this, like I always just like, that's not going to happen. Or like somebody has like the sniffles and they don't want to be around me. I'm like, you can give me a kiss. I'm not going to get sick. Like it's not going to happen. I'm fine. But I think that's because I don't know, maybe that's genetic, whatever. I was really obsessed with like the cold water thing. So that's the thing that I tell myself why it helps. I found like horror stories from medication. I do remember the one time I did get sick was 2017 Tour de Beauce, and the doctors gave me this medication, and this was an example of it really screwing with me. They gave me some medication, and I want to say it was like Avalox or something like that for a chest infection, and it got rid of that, but there was a side effect of it where like tendon rupture, and my Achilles tendon almost snapped in the race. Like I started to get this really weird feeling where it was like my Achilles tendon, it felt like crunchy. And I was like, what is going on? This is the weirdest thing. And then I did, the WebMD thing where you really scare yourself, like to self-doctor, all this stuff in the hotel at Tour de Beauce. And I'm like, oh my goodness, my Achilles tendon is almost going to rupture. And so I stopped taking it right there. Or like years later, I was at a crash-in race here in the Czech Republic, and they thought I cracked my eye socket. And so my eye was all swollen up, and they gave me ibuprofen for that. And it was the first time I'd had ibuprofen in years. And it gave me such problems with my stomach that I just had like all stomach problems the next day. So I was having more problems from this like pain medication than from the injury itself. And so I really went down like Swain Tuft again. That was my mentor. And he taught me all about like the circadian rhythm, sleep, sunlight, grounding, all this woo-woo hippie stuff that I thought was just funny at first. But I'm telling you, it works. Like I never take medicine. I never get sick. All I do is all this goofy stuff where my teammates make fun of me. But that's my opinion on it.
Jeff, that was an awesome discussion about kind of the broad spectrum, see what I did there, of antibiotics.
I like that.
I'd love, though, to touch on one in particular, because this is, let's be honest, this whole episode is about me. This is something that has affected me in the past, and that is a specific class of antibiotic called fluoroquinolone, like Cipro, Levaquin are two different types there, can lead to things like tendinitis and maybe even ligament and tendon rupture.
Yeah, not ligament rupture, but tendon rupture. Achilles tendon rupture is the one that's been associated with ciprofloxacin particularly. Not so much for some reason with Levaquin, although there is a theoretical risk. And it's not completely well understood.
Yeah.
The association, though, is so great that Cipro now comes with a black box warning. And black box warning just means that the FDA issues this warning to prescribers and basically says, you got to be aware of this, be careful prescribing this, only prescribe it to people if it's really important and necessary. The fluoroquinolones came out when I was in medical school. It was revolutionary at the time because it was the first new class of antibiotics in quite some time, and they provided us with a new way of treating gram-negative bacteria, which are particularly difficult bacteria to kill. And they were great, but we started to see these tendinopathies and tendon rupture, specifically the Achilles tendon. And there were a couple of high-profile athletes who had them, and they were obviously devastating to them. And it turns out that the Achilles tendon is the most likely tendon to rupture, and not everybody who has a tendon rupture has been on a fluoroquinolone. Yep. And not everybody on a fluoroquinolone is going to have a tendon rupture. However, if you're on a fluoroquinolone, the likelihood of having an Achilles tendon rupture is significantly higher. Fluoroquinolones are associated with a almost 4-time greater risk of a development of Achilles tendinitis or rupture. Yep. So that's pretty significant. Now, again, Achilles tendinitis isn't that common, but 4 times more common is 4 times more common.
Yeah.
And again, not totally understood why the antibiotic seems to have this predilection for tendons, but it is what it is. There are certain things that make you more likely to get this problem if you're on a fluoroquinolone. These are higher age, so age greater than 60, people who've previously been on steroids, people who have renal issues. You mentioned you've had renal issues. People who have diabetes, and people who have a history of other musculoskeletal disorders. So any or more of those predisposing factors will increase your risk for fluoroquinolone-induced tendon disorders, but you don't have to have any to still have these problems.
Yeah, for me, it was, I don't remember exactly which medication I was taking, but I ended up with like a bilateral patella tendinitis from skiing. Like my knees never hurt from skiing. What is going on? And started looking into this. And lo and behold, it seems like it might have been associated with the antibiotic that I was taking. And because of that, when a friend and a training partner had kind of like a similar complaint a few years later, I was like, are you taking blah, blah, blah by any chance? And he was like, actually, I am. And I was like, there it is, the smoking gun. But, with us as endurance athletes, I think that we need to understand, hey, you're out, you're running a marathon, you're doing a trail run, you're crashing your mountain bike. These are all things that are putting additional stress onto these components of our body. And, it's maybe worthwhile looking for alternatives perhaps in this, because I don't know. I mean, some of these things, Achilles tendon rupture, I mean, this is a pretty significant, damage, a pretty significant recovery, surgery to repair, so on and so forth.
Yeah, you mentioned earlier about, doing your own research, and I'm always a little cautious about that. The idea that going on the internet is going to somehow make your understanding of something more than the people who've really done the research is a little... I worry about that. But that's not to say that you shouldn't look and you shouldn't ask questions. You should. Just always do so understanding that you may not have the whole picture. And I say that because I watch these drug advertisements on television where they list the side effects. And I mean, they have to list everything, right?
They do. And they're usually opposite each other.
Right. And it's like, some of the side effects are waking up in the morning. And it's like, what are you supposed to do with these things? So I think you just have to be, yes, you want to be an informed patient and you want to know what the potential risks are whenever you take a medication, but just recognize that they have to list everything. And it doesn't mean that just because a tendinitis, for example, is listed, it doesn't mean that that's A, going to happen to you, or B, that common. Now, with fluoroquinolones, it's obviously common enough that the drugs have been restricted in terms of how they're used. But in any medication you take, there's going to be a host of side effects. And it doesn't mean you shouldn't take it. It just means you should probably have a conversation with your physician or your pharmacist to get a sense of how common those side effects are and what you should be looking for.
Yeah. And certainly when looking in the literature, it is definitely mixed in terms of the incidence rates and particular drugs. And there is a lot of nuance in this conversation for sure. I don't think that there's a good blanket statement recommendation that could be given.
Absolutely.
So I want to shift gears a little bit, and
it's good for a cycling.
It is good. And I shift electronic gears oftentimes too, which is nice. I want to move over to a topic that isn't talked about much. If anything, I almost think it's a little bit of a taboo topic. and that is around ADHD medications and the stimulants associated with treating that. This is something that seems like is increasingly common for people to be taking, to be prescribed. I know that there are some people in the industry who have mentioned quite openly, and I applaud them. Nate, the founder of Trainer Road, talks about his ADHD med use. I think that he's on Adderall. I could be wrong. And how that was ultimately relatively revolutionary in his life. And I think that other athletes may be taking ADHD, whether that's dexmethylphenidate or Adderall or whatever, at increasing rates. And so I'd love to talk about the considerations when taking stimulants during endurance exercise.
Sure. I think there's a couple of things that you need to think about with these medications. One is their effect on appetite, which for us as endurance athletes who are expending a lot of energy, we have to be fueled. And if we're not adequately fueled, then the ability to perform is severely impacted. And we know that these medications are associated with severe restriction of appetite in many who take them. And that is a potential pitfall. So something to be concerned about. And then the second thing is just their impact on cardiac activity. They're all stimulants. Therefore, they all have some degree of effect on heart rate. And they can increase heart rate during exercise. They can increase resting heart rate. And it's just something to be cognizant of.
Yeah, certainly. You know, I was diagnosed with ADHD a few years ago. I take dexmethylphenidate at times. I do not take it regularly, mostly because I don't necessarily like how it makes me feel, and it affects my sleep and things like that. And I haven't really cared enough to look for alternatives with my doctor. But some things that I have noticed, and I'll say maybe this is anecdotal, when I was taking medication more regularly, things like my heart rate variability was significantly lower than it was when I don't take the medication, right? And so I know that there are a lot of people that are using things like Whoop to varying degrees of success, right, with things like heart rate variability, but we can have really profound effects there. The other thing that was really interesting to me, I did a study with Dr. San Milan on some, I think I can talk about this now, I'm maybe breaking an embargo at this point, on a continuous lactate device where I had to wear a continuous lactate monitor 24/7 for a couple weeks at a time. I actually wore 4 of them during the test. But I also had to do serial finger prick lactate sticks on myself, essentially like every hour of my waking day. And it was incredible to see how much higher my resting lactate concentrations were based on taking the stimulant dexmethylphenidate, which was really profound to me. And even things like caffeine and coffee actually drove my lactate up higher. And I have noticed anecdotally through the years when I have taken stimulants like this, it very much affects any lactate testing that I'm doing. My results are profoundly different than when I haven't had coffee to drink or taking a medication like this. So ultimately, I just want to inform people that, you know, if you are doing testing like this, you know, or if you are looking at things like heart rate variability, using heart rate zones, all of that might be affected by some of the stimulant use that people are using to treat things like ADHD.
I think that's really interesting about the lactate. I'd not heard that before, and I can't think of a biochemical reason for it, but that's really interesting that that's happened, and I wonder if that is something that other people have noted as well.
Yeah.
The heart rate stuff is 100%, and so is the sleep. I should have mentioned that. I forgot about that in terms of the side effects, but the heart rate stuff, 100%. We know that a lot of different medications, beta blockers we talked about earlier, definitely impact heart rate variability. And I'm not a huge subscriber to heart rate variability. I think heart rate variability is a little bit overcalled in terms of its utility as a primary determinant of fitness or readiness, things like that. I think it's something that we can use as a metric, but I think people maybe overcall it in terms of its prime importance. That being said, almost any medication is going to have some kind of impact on heart rate variability, especially if it touches the nervous system or touches the cardiovascular system. And what its importance is unclear to me.
Yeah, we don't understand.
Yeah,
exactly.
We don't really know. And I think that's the problem with heart rate variability. I think people have gotten ahead of the, they've put the cart ahead of the horse a little bit with heart rate variability. They kind of are like, heart rate variability is based on chaos math, which means that tiny little, perturbations can have big downstream effects. And people are using heart rate variability very linearly, which is exactly the opposite of what it's supposed to be. So I don't know what decreases in heart rate variability related to a medication should be interpreted as.
Exactly.
But they're there.
Yeah.
And I think that if the medication is working and you're able to perform despite those changes in heart rate variability, then I think that's what's important. And then you just have to use that change in heart rate variability as your new baseline.
Yep.
But as you said, I think it's just important that you know and that you recognize that that's an impact or an effect of the medication. Again, back to that risk-benefit balance that we talked about earlier.
Yeah, certainly. To bring up the WADA side of this, it seems like a lot of these medications associated with ADHD treatment are not prohibited outside of competition, and they are prohibited during competition. And as far as I know, unlike diuretics, it is very difficult to get a TUE for something like Adderall.
I don't know about Adderall. So there's another one that is called, the trade name, I'm sorry, I hate using trade names. I prefer to use just the generics, but modafinil is another one, and that is used by shift workers like myself.
Okay.
So it is often used by emergency physicians or nurses or people who have to do night shifts on a changing schedule, and we'll use it to help us get through the night shift.
Mm-hmm.
And I called WADA about it because it is listed on their banned in competition list. And I called them up and asked them about a TUE, and they said, we know shift workers use this medication. It is banned in competition. We know it has a very long half-life. If you ever tested positive, you would just come and talk to us, explain what your job is, and it would not be an issue. And I kept that conversation. It's in my in my to keep folder of my emails.
Yeah. I swear I'm a doctor. I'm not just a podcaster. Changing gears. Our attention span for ADHD drugs is just out the window at this point. I brought that up because it seems like the prescription of that is increasingly common. And I think that the same can be said for the last class of medications to talk about today, and that's anticoagulants. As you mentioned off air, we are seeing increases in atrial fibrillation, maybe associated with athletes, and because of that, an increase in the prescription of anticoagulants as well.
Yeah, as we get older, as we're on the bike for more and more years, we're prone to what's called ventricular enlargement or ventricular hypertrophy. And that's normal. It's not dangerous necessarily, but it makes us prone to arrhythmias or dysrhythmias, and the most common one is atrial fibrillation. Atrial fibrillation in and of itself is not necessarily dangerous, but the problem is if the atria don't beat in a coordinated fashion, they come to a sort of a standstill, and the blood that pools within the atria can clot. And if one of those clots suddenly becomes dislodged, it shoots off to the brain and causes a stroke. And atrial fibrillation remains a very high risk factor for strokes. And the way to treat that is to put people on an anticoagulant so that they don't form clots. And the use of anticoagulants has been a boon to decreasing stroke occurrence in patients who are at risk or who have atrial fibrillation. There are risk scores that exist in order to determine the likelihood of stroke in patients who have atrial fibrillation, and you don't have to score very high on that risk score in order to be recommended to be on an anticoagulant. And what that has resulted in is a lot of people in their 50s and 60s who continue to be very active, including on bicycles, who are taking these medications. And where it used to be the medication that was taken was warfarin or Coumadin, which was a medication that was easily reversed. We now see people taking medications like rivaroxaban or all these other newfangled, they're called NOACs, novel oral anticoagulants.
Right. And so like what, Lovenox is a brand name in there?
Lovenox is a low molecular heparin, which is injected.
Take it out. This is why I'm not the doctor.
There are all kinds of different anticoagulants, but the NOACs are these novel oral anticoagulants which have revolutionized the use of anticoagulants. So it used to be everybody was taking warfarin or Coumadin, and what would happen is that once or twice a week they would have to get their blood checked to make sure that they were taking the medication in the right dosage and that they were anticoagulated to the right amount.
Yep.
With the NOACs, there's no need for monitoring. We know based on your renal function and the dose of medication you're taking that you are precisely anticoagulated. The medications work great. The only problem is that if you bonk your head, I can't effectively reverse those medications. With Coumadin, I could give you an antidote and that would stop your bleeding. with a NOAC, we don't really have effective antidotes. If you start bleeding, you have a big problem. And cyclists are, unfortunately, especially if you're racing things like crits, you have a common habit of falling down and hitting your head. And even wearing a helmet's not going to stop you from having a serious bleed.
And so we're not talking about the downside of scraping your elbow and continuing to bleed as you finish your bike ride. We're talking about something a bit more serious.
We're talking about much more serious than that. Now, that's not to say that cyclists on NOACs shouldn't be participating in cycling events. It's only to say if you're on one of these, you have to be very aware, and the people around you have to be very aware, because if you fall and hit your head and lose consciousness, people have to know immediately that that is a high risk and you have to be transported to emergency, and somebody there has to know that you're on one of those medications. That's really all we're saying.
So how can somebody make sure that that information is easily known, especially in a situation where they lose consciousness?
I am not sponsored by, nor am I promoting any particular product, but I have on my watch, on my Garmin, I have one of those road ID little thingies.
Yeah, there it is.
That talks about who should be called in a emergency and what medications I'm on. So that's one example. As long as you have that information, as long as somebody knows that information, as long as it's very easily ascertained that you're on those medications.
Yeah.
Honestly, if you're on a NOAC, a crit is probably not the kind of event you should be participating in.
Sure.
But listen, if you're on a NOAC, you could be descending and your tires could slip out on some gravel. So, I mean, you could still have problems.
Crashes happen, right?
Yeah,
I mean, we can all attest to that.
Risk benefit. That's what we're talking about here. But I think the point of discussing NOACs is not whether or not you should be taking them. That's a conversation that you're going to have with your physician. And you're going to make it very clear, look, I'm a cyclist. I'm not going to stop riding.
Yeah.
But your doctor needs to know that you're a cyclist in order to make a decision about which medication is best. Because of the NOACs, there are a couple of them that we can reverse more efficiently than others. And if you are doing crits, maybe you need to adapt, as we said earlier, or maybe the risk of being on that medication is higher than the risk of stroke, and maybe you're not going to be on a NOAC during the time that you're racing.
Yeah. I think that you mentioned something that I just want to repeat. And that is having the conversation with your doctor. I think that sentiment has come up multiple times throughout this. And I just really want to highlight it because it's very much a patient-doctor relationship. And you need to be able to have an honest and frank conversation with your doctor so that they are well informed. Because all of this is part of the decision-making process. And your doctor ought to take all of this information into account when thinking about the best therapeutic course moving forward. And, if you're not forthright with this really important information, then the doctor is going to make the best decision they can on incomplete knowledge. And so it can be hard, and I understand it, right? It's probably really easy for an ER room physician to say, hey, man, just talk to me about it. I think that a lot of people kind of view doctors as sort of this, I don't know how to really describe it, but like doctor knows best, right? And I'm just going to do whatever the doctor says. But that doctor, they're on your side and they want to do as best by you as well. And so, make sure you're having those conversations.
And ask questions. We're all busy and we often have a lot of pressures on us to see more patients or to do certain things in a certain time frame. But don't be shy to get your money's worth and make sure that you get all of your questions answered. And if your doctor says, look, they don't have time or whatever, then say, well, how can I ask you questions? Because many doctors these days will have a means for you to contact them electronically and ask your questions that way. So don't be shy. You're the patient, you're the customer, and you should feel satisfied that you got all of your questions answered in the way that works for you.
Awesome.
The more you measure training data, the more important understanding it becomes.
In our advanced performance data analysis pathway, we move beyond the basics to explore more complex data analysis. We help you navigate complex techniques so you don't get lost in the numbers.
This pathway features Tim Cusick, Dirk Friel, Armando Mastracci, Coach Dean Golich, Joe Dombrowski, Trevor Connor, Dr. Stephen Chung, and me, Ryan Kohler. We also explore advanced features of WKO, Training Peaks, Exert, and Intervals.ICU.
We use the term deep dive a lot around here, but this is our deepest dive yet into performance data analysis. Follow our advanced performance data analysis pathway at fasttalklabs.com.
Before we sign off, Taylor Warren has some sage advice for evaluating the need for medication. But as always, please discuss with your doctor.
I've never taken medication, and even like, common painkillers, Advil, Tylenol, it's like I'll take those very, very sparingly. There's a saying I really enjoy, and it's there's no solutions, only trade-offs. And that quote comes to mind when I think about medication, where a lot of times medicine or medication, especially in our modern day, it's really a band-aid to cover up a symptom. So you're not actually taking care of the underlying issue. You're just putting a band-aid on the symptom of that issue. And I think that is a mistake in most cases, because you're basically blocking signals that your body is trying to tell you, right? Your body, if you have a headache, your body's trying to tell you something. It's not an excuse to take a painkiller to make the headache go away. It's an opportunity to learn why your body is giving you the signal and to learn more about your body. Maybe you're dehydrated. Maybe it's something really common and easy to fix. That's kind of my opinion on medication. I think, medication is necessary at some points, maybe as more of like a last resort type application. But I think in general, people are overprescribed and they're not actually doing their body, any good taking medication.
Well, Jeff, absolutely incredible episode today. If anyone enjoyed, hopefully everyone enjoyed this episode, but check out Jeff's podcast, right? What's the name of it?
It is called the TriDoc podcast. It can be found on all the usual platforms.
Love it. Awesome. Well, once again, thank you. Appreciate it.
Absolutely. Enjoyed being here.
That was another episode of Fast Talk. The thoughts and opinions expressed on Fast Talk are those of the individual. Subscribe to Fast Talk wherever you prefer to find your favorite podcasts. Be sure to leave us a rating and a review. As always, we love your feedback. Tweet at us at Fast Talk Labs or join the conversation at forums.fasttalklabs.com to learn from our experts at fasttalklabs.com. For Jeff Sankoff, Brady Homer, Dr. Steven Seiler, Jack Burke, and Taylor Warren, I'm Rob Pickles. Thanks for listening.